morning, good afternoon, and good evening to our speakers, chairs, and audiences of the ACNS webinars in different parts of the world. We are back again with another session of educational lectures just for you. The first speaker of today is our honored guest from Chile, Professor Jorge Mura. Professor Mura is the professor of neurosurgery at the University of Chile, and he is the chief of cerebrovascular and skull-based division of Department of Neurosurgery, Institute of Neurosurgery, SNJO. He is also the president-elect of the Chilean Society of Neurosurgery. His research and clinical interests are focused upon skull-based and cerebrovascular surgery. He is a noted academician and proficient surgeon who has published several articles in various peer-reviewed journals. We are extremely honored to have him today as a speaker at our webinars. Today he is going to talk about MIPLATTA, which is minimally invasive posterolateral transcavernous transtentorial approach. The second speaker for today is our honored guest from Palestine, Dr. Imad Talama. Dr. Talama is a consultant neurosurgeon at the Al Hilal Specialty Hospital, Hebron, Palestine. He began his work in Italy as a consultant in neurosurgery in Milano Private Hospital and moved to Libya to establish the neurosurgery department in Benghazi Medical Center. He worked there until the war started, and he helped the Libyan people by doing critical surgeries during the first month of war. And then he moved to France and then to Palestine. He has been working in Palestine for the last 9 years, and he has performed more than 5,500 surgeries till now. He is covering many of the Palestinian hospitals in the West Bank area, and he is guiding many of the Palestinian neurosurgeons to raise the Palestinian neurosurgery up to compete with the international levels. We are extremely honored to have him today as a speaker at our webinars, and today he is going to talk about lumbar fusion in resource-limited setting. The chair for the first session of today's webinar is our distinguished faculty from Japan, Professor Naoki Otani. Professor Otani is Associate Professor, Department of Neurosurgery, Nihon University School of Medicine, Tokyo, Japan. Professor Otani is an integral part of the Japanese Neurosurgical Society and several other neurosurgical societies around the world. He is a noted author who has published several articles in neurosurgery, and he has been decorated with several awards and honors for his outstanding contribution towards neurosurgery. We are extremely thankful to him for accepting our invitation to chair this session of webinar. The chair for the second session of today is a special guest from India, and indeed he is special for me as well because he is my boss and teacher, Professor Anil Kumar Pitambaran. Professor Pitambaran is the head of Department of Neurosurgery at the Government Medical College Hospital, Trivandrum, Kerala, India. Professor Anil is a proficient surgeon and an academician. He is the innovator of the surgical technique of 4-quadrant decompressive craniotomy, and he is a noted author of several articles in various leading journals. He has trained several batches of neurosurgery residents from various parts of the country, and we are extremely honored to have him today to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the distinguished audiences to this online platform of ACNS webinars. A special welcome to Professor Shubin, who is the main mentor of ACNS webinars from China, and he has arranged this WeChat broadcast for this webinar today. Dr. Alberto Faletti is our special co-host for today. Welcome, Alberto. Alberto is a consultant neurosurgeon at Department of Neurosciences, Biomedicine and Movement Sciences, University of Verona, Italy. Dr. Liu Bun Singh from Malaysia is my regular co-host for today. Dr. Alberto is integral part of our educational committee of the ACNS, and he also serves as the president of the Fujita Alumni Association. And with that introduction, I would like to hand over this platform to the first chair, Professor Naoki Otani.
So I'm very honored to meet Professor George Mura and every friend. So today I'm honored to chair the first session of the George Mura. So he is one of the most internationally well-known and well-experienced neurosurgeons, and he has published so many reviewed papers, in particular about less invasive approach for very cavernous sinus lesions. So today, I have heard that you, Professor George Mura, give the lecture, the minimally invasive posterolateral transcavernous transtentorial approach. I have been very much looking forward to hearing your lecture today. So, Professor George Mura, please.
Good, for me, it's good morning. For me, it's a great honor to be here with you, showing my experience in trying to do a less invasive approach for cavernous sinus lesions. In our language, in Spanish, the acronym of minimal invasive posterolateral transcavernous transcensoral approach is MIPLATTA. MIPLATTA in Spanish means my money, and then it's a good way to remember the approach for us. And the first thing I want to say is, as I said before, I'm very honored to be here with you today talking about this. This is a philosophy that I learned mainly for Japan. I made a fusion between the things that I learned with Professor Evandro. I was his fellow. My master was Evandro de Oliveira, and I made a fusion with the Japan philosophy about the management of the cavernous sinus, and with other friends that I will show to you in my presentation. They show me that minimal invasive surgery for complex lesions is possible, because when you have a high volume pathology, you need to be more efficient in order to treat the patients in a better way, and the patients tolerate better the procedures that you're going to do to them. I went with Professor Evandro in 1998, and I spent 1 year with him, and I learned with this team two very important things that you need to apply in your practice. The first, the microsurgery. The microsurgery is very, very important. This is Elder Tedeschi, one of the best surgeons that I know from Brazil. And for microsurgery, you need good instrumentation. You cannot operate with anything. You need good instruments. It's very important. For endoscopy, it's very clear. The best endoscopists in the world cannot operate without the endoscope. And then why the neurosurgeons accept to operate without the best instrument? For me, it's very important. And the other thing is the neuroanatomy. The neuroanatomy that I learned there. And when Hun Tzu was one of my most important masters, is from Dr. Evandro in that time as well, team. And he teach me a lot about neuroanatomy, the importance of neuroanatomy. The neuroanatomy for us is the key to perform a good surgery, to imagine what happened with the structures, with the pathology and everything. And this picture that I put here is a dissection that Elder Tedeschi gave to me, the picture, more than 20 years ago. And here is the key of the approach that I will show you today. Because if you see the interpeduncular cistern, the crural and the ambient cistern, and you see through the middle fossa, and you take out all the dura mater and the tentorium, you can see everything in the posterior fossa, and there's no bone there. The only bone that you have there is the Kawase triangle, or for some people the Hakuba triangle, because Hakuba described before Kawase, the anterior petrossectomy. And then if you see there the space that you have in between the fourth and the fifth nerve, you can go very, very low in the posterior fossa. The only thing that you must be careful is with the sixth nerve, okay? And then we show you that is possible, because the concept of MIPLATTA is I'm going to use the cavernous sinus like a highway to get to the posterior fossa. I learned this phrase from Ali Krish, very good neurosurgeon who worked in the United States. And I think about this. Why you need to be afraid with the structures? And then what happened to me in 1998, I was with Argentinian neurosurgeon, and I started to study the region of the dural rings. The dural rings and the release of the carotid artery, the release of the optic nerve is the key for the surgery. And the other thing I have was very lucky, because in 1998, Professor Hakuba went to Brazil in September the 3rd, and I knew him. And he was very kind person, and he gave me his book of skull-based surgery, and was for me a really changing experience in my life to see all the things that he described, the orbitozygomatic approach and a lot of things more. And I started to study the papers, and I have this paper of 1982, 1 year before that Dolenz. And in this paper in Japanese, is described the lateral wall of the cavernous sinus, the opening of the Parkinson triangle, which is the key is the key for the surgery, the extradural anterior cranioidectomy and the anterior transpetrossal approach. Everything is here. And what I did in 2019, I translate the paper to the English. And in that paper, for anyone who wants the paper, I can send for email, you can see the description of everything. It's very important to make justice about history. And then there's a history about the anterior clinoid, because I start with the most applicable thing in the cavernous sinus, the management of paraclinoid aneurysms. I start there 20 years ago. And then I start to study the history. The history is the Americans use the subdural dissection of the clinoid because they learned from Drake from Canada, who described the carotid ophthalmic aneurysms in 1968. But the Japanese and the people from Europe, they learned from the Hakuba and Dollens. And that's why they prefer to do the extradural or the combined approach. And I was very lucky to know very good surgeons from Japan. Here is Rokuya Tanikawa, Professor Kamiyama, and my friend Kiko from Spain in 2007, a lot of years ago. And I learned the philosophy of the instrumentation. The instrumentation very important. Then the cavernous sinus, what happened with the cavernous sinus? Everybody think the cavernous sinus is a few months land. Because it's, when I made my residency, they said cavernous sinus is no man's land. Nobody can operate the cavernous sinus because it's impossible. And that is not true. I think we must change the concept that it's a few man's land. It's a land that you can navigate. You need to know neuroanatomy. You need to know how to deal with the problems of the cavernous sinus, but you can operate in the cavernous sinus. But the first thing is know the anatomy. That's why I put here again the anatomy. And the other thing, you need to start with something. I start with paraclinoid aneurysm. And now I have more than 400 cases of paraclinoid. And then I know a lot about the roof of the cavernous sinus and the lateral wall of the cavernous sinus because I do extradural cranioidectomy. And then we need to go further to that. We need to expose completely the cavernous sinus. And what I'm going to show you today, the only difference with the approach that the Japanese do, for example, of the people from Europe or any place, we use minimal invasive approach. We try to change the concept of keyhole approach. The keyhole approach is just the size of the craniotomy. If the craniotomy is small, you have a keyhole. But for the skull base, that is not enough because you need to expose in the bottom of the field. If you don't expose in the bottom, you cannot do nothing. This concept I learned from the endoscopy, the transnasal approach. What you do with the endoscopy in transnasal approach? You take your operative field to the bottom, to the nose, because you put the endoscope in the bottom of the surgery, and your surgery start there. That's what I try to do with my surgery. Is try to put the surgery in the bottom, and then we start to describe the classic thing is the Dollens approach or Hakuba approach, how you prefer, which author you recognize as the first author. For me, is Hakuba. And then we start to do the mini-pterional approach on the macropterional approach, the real keyhole. But instrumentation is very important, and I learned that in Japan. And the first thing is the concept of suction irrigation. Suction irrigation in microsurgery is very important because if you want to do minimal invasive, you need to use suction irrigation. In Asia, a lot of surgeons use suction irrigation, in Japan mainly, and it's very, very important. I learned from them in 2015. And the other thing is the scissors. The scissors are the key of the surgery in the cavernous sinus. And the Kamiyama scissors and the shape of moonlight, you know, the circular shape gave you the opportunity to the tip of the scissors never hit the nerves, and that's very important to release the nerve in the cavernous sinus. And then we changed in 2015 the surgery. We went first with the Johannes-Niemi approach, the supraorbital. But the problem with the supraorbital is you open the frontal sinus. With the frontal sinus is very big. The mini-pterional approach, you never open the frontal sinus because your upper limit is the superior temporal line. That's very important. very important for skull base. Skull base, the main complication in skull base is a CSF leak, and you need to prevent the CSF leak. And for me, it's very important to teach because my young fellows, they always give me very good ideas. These are Alejandro Cook and Rafa Martinez, two of my fellows. Now they are surgeons, vascular surgeons. And we start to talk in that time about how we can go for a minimally invasive surgery, going from Jasarkil, or Spetzler and Figueiredo, who described the mini-perional, or the Yuha approach. What are you going to do in order to do a less invasive approach? And I found this paper from a Mexican, this fellow Rich, a keyhole approach. This is a keyhole from Edgar Natal from Mexico. Very interesting mini-perional concept. But in order that I learned in Brazil, I learned to do the interfacial dissection. And that's the difference of the mini-perional craniotomy described for Figueiredo and Spetzler in 2007. This is the base of our surgery, but this is a subdural surgery, okay? But the key in this surgery is the superior limit, is the superior temporal line, and you prevent to open the frontal sinus. It's very less invasive compared with the perional. And this picture I take with both of them, Natal in my left side and Figueiredo in my right side, and the people who describe these less invasive approaches. And then the keyhole, typical Pernesky concept, is the small size craniotomy. And the mini-perional can be a keyhole, but it's not proper a keyhole because the keyhole only you have the limit of the size. In this case, you have a neuroanatomical definition. The mini-perional is to the superior temporal line. That's the limit. You can go back or down, whatever you need for the patient. And of course, there's a study comparing the perional with the mini-perional in order to see there's difference in these two approaches. There's no difference. And then we change. We go to the less invasive with a new concept, the key exposure concept. That's the concept I want to show you today. What is a key exposure? The key exposure is the smallest opening in the outside with the biggest opening in the tip of the surgery. That's the concept of this kind of approach. And here is what the draws what we do with my fellows, and the difference, for example, between the classic Jasarkil big opening outside and the target is fixed in the bottom, for example, the Cindy Fisher. The keyhole, for example, for Pernesky, a small opening in the outside, and you use the endoscope in order to widen the dip. But the problem when you have dura mater, bone, or whatever put in your way, the keyhole you cannot apply the pure keyhole concept because you need to expose in the dip, and that's where the Hakuba, Kawase, Dolens, all the people contribute in order to do this kind of approach. And of course, you need to do dissection. This dissection were did in my country for a Rotom fellow. That was fellow of mine, and after that was the only Rotom fellow from Chile. And this is the extradural mini-perional. That's the difference that we invented. The mini-perional is subdural, described in 2007, but now we did this extradural. It's possible to do without a huge craniotomy this kind of surgery. Of course, that is possible, and you can do everything. You can expose all the structures. If we start to publish this, the keyhole, the micro Hakuba approach, the ophthalmic aneurysms treated for this way, the extradural mini-perional, the comparison of the exposure in paraclinoid. Why I show you all these papers to you? Because it's important to publish. Because if you don't publish, nobody knows what you are doing. And it's very important that you need to publish in order to do what we are doing today in this webinar, to share our experiences and try to improve our surgery. And then we finally, the last year, 2020, we can publish the approach as for all the pathologies, the extradural mini-perional approach. This approach is not the approach we're going to talk today. The approach we will talk today is more than that. It's the next step. Okay, the instrumentation are your secret weapons. Without that, you cannot do this surgery. If you don't have suction irrigation, if you don't have good scissors, for me, Kamiyama scissors, it's impossible for me to do this surgery. You need to try to do your own kits of surgery. We prefer to do the no drill technique to take out the clinoid. We don't use a drill. Recently was published the difference between no drill and drill in order to prevent the optic nerve function, and it's much better the no drill technique to preserve the function of the optic nerve. And I'm going to show you some examples why and how I get finally to the MIPLATTA approach. For example, trigeminal schwannoma. This is a typical trigeminal schwannoma that I did. You can do for retrosigmoid approach, you can do for middle fossa. I prefer to do for middle fossa because the tumor made me the space in the posterior fossa, and I can take out all the tumor in one step, one stage only. If I go from the back, I need to do a huge surgery or do a stage surgery. And then you can see here the bone is intact, because when you have a huge trigeminal schwannoma, the tumor made you the Kawase approach. Then I see a lot of people talking about the Kawase approach in trigeminal schwannoma. The problem is when you try trigeminal schwannoma, the tumor made you the Kawase. Then you don't need to drill. Kawase is when you drill. If you don't drill, it's not a Kawase. If the tumor made you the difference. Then this is the view, only to show you the view. The view is for mini terional. It's not terional, because we use microscope in very early stage in the surgery. And then you do the middle fossa approach, the peeling of the layers of the cavernous sinus. And after that, you can enter the cavernous sinus because you have tumor. And it's very important other concept. You need to preserve the trigeminal nerve, the trigeminal schwannomas. You don't need to cut it. I heard some surgeons said, no, you need to cut the trigeminal nerve. No, you don't need to do that. You need to preserve. This is trigeminal root, B1, B2, B3, Kawase triangle, and we're going to drill in order to make exposure in the deep. This is nothing new. This is the same that everybody do in the world, you see? But the difference is we are doing this for a mini craniotomy. This is not terional, this is not transzygomatic or vitozygomatic, because I know the surgeon that said that it's impossible to do this without take out the orbit or the zygoma. That's not true, because this is mini terional. And we can do without take out the orbit or the zygoma, because I was this kind of surgeon. I was a surgeon who always said, it's impossible without taking out the orbit. It's impossible without taking out the zygoma and everything. I was very critical with the surgeon who tried to do less invasive. But you can see here, we take out all the tumor. All the tumor, the posterior fossa is clear. We preserve the trigeminal nerve. This is the pons. Minimally invasive approach. You can take out all the tumor. You can take out the Kawase. Okay. Then the next step is sphenopetroclimal meningioma, more complex pathology. Terrible. Ossification of the tentorium. Cavernous sinus tumor, middle fossa tumor, posterior fossa tumor. A nightmare. For me, it's a nightmare, this tumor. And then I went for the middle fossa. This is a mini terional. What I learned in these patients of sphenopetroclival, I learned that the middle fossa is very good tolerated for the patient. You can release the nerves of the cavernous sinus. This is the third nerve, the fourth nerve. It's possible to relieve the nerves. You can take out all the tumor, release the fifth nerve, preserve the nerve, take out the posterior portion of the tumor, and you preserve the optic, carotid, third, basilar, fourth, fifth, everything. This is a mini terional approach. That's the difference, you know? And of course, you have some swelling of the temporal lobe, but it's because we need to cut the superficial cilium vein. But this is the MRI of this patient after the surgery. And I take a picture authorized for the patient, because with this patient, I learned that I can navigate through the cavernous sinus to the posterior fossa. I learned that. But I want to say that no idea is new. Always somebody said what we are saying before. And I found this paper from the people of Taiwan that they made the same approach, but using a pterional classic transzygomatic approach. That's the problem. The problem is we need to apply minimal invasive concepts, okay? And then that's the MIPLATTA concept. MIPLATTA is applied a minimal invasive surgery for a very complex pathology. But what's the problem? The problem is the bleeding of the cavernous sinus. But we have a solution for that. The solution is the tentorial is the dura mater, but you need to preserve the nerves. If you take out the dura mater, you can see the posterior fossa. It's very clear. But the venous concept, you need to know it, you need to use in venous content fibrin glue. Fibrin glue is very good in order to occlude the venous bleeding. But you need to use rational. You cannot put 3 milliliters of fibrin glue in the cavernous sinus because you have a problem in the venous drainage. You need to put in very specific spots the fibrin glue in order to only occlude the part you're going to open in your surgery. And then the experience is very, very old. First from Checar, after that for Leakage, of course, and Yuha. We have this very recent paper about the fibrin glue in transcavernous surgery. Professor Otani was one of the authors, and showed the change in the drainage when you use this tamponade with the fibrin glue. And the most important thing, and I agree completely with them, is the volume. You need to use less than one milliliter always. You don't need a high volume of fibrin glue. And then for the venous content of the cavernous sinus, fibrin glue is very good. And for the superior petrossal sinus, you need to use Surgicel. Because if you put fibrin glue in the superior petrossal sinus that you need to open in order to release the fifth nerve, you can occlude the jugular vein. You must not use fibrin glue in the superior petrossal sinus. And then Leakage, I like a lot him because he made a very similar surgery, is the same. And you can apply the concept, for example, to use the cavernous sinus in order to clip a PCOM aneurysm, very complex. And with a short carotid, but you can use the cavernous sinus. The cavernous sinus, you must not be afraid of the cavernous sinus. You need to use it, and you can use this with minimal invasive concept. That's the only thing I want you learn today about is possible to do with a minimal invasive concept. This is the very thing I put in my comment of the paper of Leakage. And then the classical pretemporal transcavernous approach did for Dolens, Evandro, and Leakage, they using the roof of the cavernous sinus. They release the third nerve and take out the posterior clinoid. But because they do subdural dissection, they need to open the sylvian fissure widely and mobilize the brain. That's a problem for me. And that's why we prefer to use the mini-pterional interfascial approach. This is the typical subdural dissection. You can see everything for a mini-pterional, but what we do is an extradural dissection. We use the Hakuba concept. Why? Because if you use extradural dissection, you gain a lot of space and you can retract the brain protected for dura mater. And the brain, when it's protected for dura mater, is much, much better to manipulate. When you don't have the dura mater, you need to split the sylvian fissure. In this case, you don't need it. And that's why you can do minimally invasive for this. For example, if you want to do a transcavernous classic one, it's impossible to do for a mini pterional. So you need to do a pterional classic one because you need a space. And then this is the deep opening, and this dissection is for Paulo Rubino, a friend of mine, who made this dissection. You can see in the bottom everything. You can see the third nerve, the fourth nerve, the carotid artery, the sixth nerve, and the fifth nerve. But you have the dura mater in the back of the cavernous sinus. You can take out that as well. And then this is not my concept. It's a concept, of course, of other author. This is from William Caldwell. He was the one who had the best explanation of the release of the nerves in the cavernous sinus to improve the function in meningiomas. But we need to apply this in patients who don't have pathology in the cavernous sinus, who have pathology in posterior fossa. And this is the same study that he published in 2019 with the very good results in the cranial nerves. And we published the same with the sphenopetrocleiva, very good results in the nerves, because we use this philosophy of preserve the nerves and take out the tumor. We have now 100, more than 100 petrocleival tumors, and sphenopetrocleiva meningioma more than 50 now. And the results are very good, and the patient tolerate very well. I already showed this patient. And that's the MIPLATTA philosophy, is use, this is dissection from Rafa Martinez, my fellow. You use the cavernous sinus, you take that with the dura, you release the nerves, and finally you take out the back of the dura, and you can go very low. And finally, if you want, you can open the sylvian fissure and you can expose everything. And this is the classic unroofing from William Caldwell, published. And this is our unroofing, because we take out the roof and we take out the floor. The floor is the dura mater in the posterior fossa after you take out the petrous bone. And for example, in this case, I operate a few weeks ago. This is a recurrent chordoma, okay? And you say, what can you see applying the surgery? I want to show you this. This is a mini perineal approach. I take out here the petrous bone. Here is the carotid artery, and this is the basilar artery, the left sixth nerve, the right sixth nerve, the fifth nerve, the fourth nerve, the right vertebral artery, the left vertebral artery, the low cranial nerves. In the icy green, you can see the anterior spinal arteries. And then the limit that you have in this kind of surgery is not the size of the craniotomy, is what you have in the bottom. In this case, the pathology provide me a room in order to see the foramen magnum, because I can, if I move the microscope, I can see everything. This view is a mini perineal. Here is the size of the craniotomy. 4 centimeters long, and the view is in the posterior fossa. And then it's very important to show you. This, of course, is the tomography of the patient. You can see it. We take out everything. And then this is the concept that I want to give you to you today. The size of the craniotomy is not the key. It's exposure in the bottom. And then, for example, in this case, we have this epidermal cyst from in front of the medulla to the middle fossa. And then we can do a lot of surgery, retrosigmoid, middle fossa, a lot. But if you use the MIPLATTA concept, we can see that the tentorium is here. If we take out the tentorium, we can go to the posterior fossa. You see, the tentorium is here. This is the middle fossa. We can use this space that gives the tumor in with the temporal lobe, because it's right side, and we can, I think, take out the tumor through almost the foramen magnum. Everybody said that with the Kawase approach, you cannot get the foramen magnum. That's not true. It depends on the pathology. And then this is the surgery, the same surgery that I showed you. This is the pinning of the middle fossa. We take out the anterior clinoid, extradural, and then what we do is push the dura mater and start to occlude the venous contest of the cavernous sinus. This is the optic nerve, the clinoid triangle, and now we are open the dura in the cavernous sinus, and you can see here the carotid artery, the sixth nerve is here, the dura in the back, and we start to release the nerves. Now, this is the optic, carotid, third, fourth. You can release everything. Third nerve, fourth nerve, sixth nerve, fifth nerve, and we were going to talk the back of the cavernous sinus without lesion of no nerve. And we see the epidermoidal cyst in the posterior fossa. And now we are opening the porous trigeminus. We take out the bone in order to mobilize the fifth nerve that is here, that is pushing back from the tumor. And then what we do next is, you see, take out the bone below the fifth nerve in order to get the pontomedullary union. And we can do, of course, a Kawase extension of the surgery. And finally, we take out here and we take advantage of the tumor in the temporal lobe. This is no retraction. This is natural, no retractors, only the space that the tumor gives you, and you can take out everything. We take out the Kawase because I want to release the facial nerve as well. And we mobilize the fifth nerve to the front and take out the tumor and release the facial nerve. And then you can use the cavernous sinus as your highway. You take your tumor in the posterior fossa in one stage, and the patient have no new deficits with no new cranial nerve, and very well tolerated surgery, very good result. This is the anatomy. If you compare what we see in the surgery is the same. And if we do an icy green of this patient, we can see the subdural carotid artery here and the intracavernous carotid artery here, the posterior knee, and you know that in the posterior knee is the sixth nerve in the lateral side, and the sixth nerve is preserved, you see? And then finally, here is the tomography and the MRI scan, of course, of this patient, and the diffusion show you that only a tiny portion of the tumor is in front of the medulla. We take out everything, all the tumor in one stage, and in a minimal invasive craniotomy. It's very important. And this is the last case when this one I'm going to finish, show you that everybody can say that no, that this is only for pathology that is not complex or not so complex or a good brain. But this is a case of high grade subarachnoid hemorrhage with a dissecting superior cerebral artery aneurysm. The patient have hydrocephalus, a drainage was needed for this patient, and an infarction in superior cerebral artery can view in the tomography, and a dissection of all the superior cerebral artery is presented here in the right side, and the endovascular people cannot occlude the superior cerebral artery. It was impossible. And the patient rejected the surgery at first and rebled. And after the second bleeding, she tolerated and she won the surgery. And what we do, the same concept I want to show you. We use the cavernous sinus as our highway in order to get the superior cerebral artery. And this is a mini pterional craniotomy. It's not a pterional. It seems like pterional because we use the microscope. Please use the microscope more than you use today, because when you use the microscope, you can go to a small opening. A small opening is less morbidity and very well tolerated for the patient. The same thing, we open the dura in the bottom because I want that the dura mater protect me the brain. And this is of course, this case is different because we have a lot of bleeding. Look at the shape of the scissor that I told you. Because the scissor is curved, you don't hit the nerves with the tip. You follow the nerves with the scissor. The instrumentation is very, very important. The Kamiyama scissor gives you that. This is the release of the third nerve. We need to release the third nerve. Why? Because the superior cerebral artery is below the third nerve, and then I can follow the aneurysm if I find the apparent origin of the third nerve in the brainstem. It's very important anatomy. Never forget the anatomy. The anatomy gives you the space. This is the posterior clinoid. Everybody say, okay, you need to take out the posterior clinoid. You don't need that. If you take the tentorium, you don't need to take out the posterior clinoid. The people who do that, I'm sorry, but I will show you here that it's not necessary. And here we're opening the porous trigeminus. You can see the fifth nerve. Why? Why you need to see the fifth nerve? because I want to see the aneurysm that is very long, and I want to do a trapping. In this case, I can do a bypass, a STA superior cerebral, but remember the patient had an infarction, and there's no need to bypass, but it's possible to do the bypass. And what we have here, all the anatomy, third nerve, fourth nerve, fifth nerve, aneurysm, basilar tip, posterior cerebral artery, and rupture aneurysm. And here the instrumentation is very important. And what we use here, I use one thing that I learned with Yuha, use adenosine. I use adenosine here because I want a soft aneurysm in order to clip. And then the next thing is use a proper clip. This is the clips, a new model of clip from Peter Lasik. I designed the applier. This applier rotates 360 degrees and is flexible. And then you can see here clearly we are putting the clip in the neck of the aneurysm with a very small room, but in a very, very sure, very safe condition. And after that, you know, I put a distal clip because I want to send up to biopsy the aneurysm, and I put a distal jazzal clip. And here, after that, I cut the aneurysm and I resected the aneurysm completely because I want to see, and the aneurysm was a dissection of the superior cerebral artery. Then for dissection, there's no treatment. You need to take out the artery because all the artery is pathological. And then very well tolerated surgery. The brain was protected. The closure of the surgery is very easy. You only need to close to the periorbit and put a few stitches. Very well tolerated for the patient, and you can cure a patient that for any vascular surgeon is a very complex case. And this is the IC green of the patient, only to show that the posterior cerebral artery is completely normal, and the superior cerebral artery is cut because of the pathology. This is the first CT scan, very good. The CT angio, I want to skip this only to show you that the trapping was done properly, and you can see that the aneurysm was below the posterior clinoid. And everybody said to me, you need to take out the posterior clinoid in this aneurysm. No, because I use a posterolateral transcavernous approach. You don't need to take out the posterior clinoid. And then I want to show you this. Here you can see the trapping. And this is the long follow-up of this patient. This patient required a CSF shunt because of the bleeding, but the patient is perfectly well with no deficit. And we use, in a minimally invasive fashion, we use the cavernous sinus as a highway to reach the posterior fossa. And then this is the MIPLATTA concept. This is real extradural mini pretemporal approach. Why I put pretemporal? Because my professor, Evandro, described the pretemporal approach in 1995. And this is a minimally invasive version of the pretemporal approach of my master. I want to thank to my fellows. We have now 48 between fellows and people who pass with me in my service, and from a lot of countries. We are very proud of them. They do this surgery where they working, and without them, for me, it would be impossible to do this kind of surgery, because the best ideas come from the young people, not for the old people. And thank you for your attention. We organized the Latin American Congress in Chile in 1998. I invite all of you, hopefully in person, in 2024 to the Latin American Congress in Chile. Thank you for your attention.
Yeah, thank you so much for your presentation, Professor Mura, showing your excellent techniques and basic concept of performing the less invasively the transcavernous transtentorial approach. So, so any question and comment from our audience?
Yes, I think we can invite comments from the
Really? Okay.
the audience, definitely.
So then I will ask a few questions.
Okay.
So yeah. So in the the final in your final cases, so you use so clip applier for the ruptured SCA annulins. You are special instrument, right? Yeah, very.
Yes. As I told you before, for this kind of surgery, the instrumentation is very, very important. And I learned from you, from Japan, the suction irrigation. The suction irrigation is the key for this surgery. For any minimal invasive surgery, you need to use suction irrigation. It's very, very important. Without suction irrigation, it's impossible because your assistant have not enough space in order to put, for example, the irrigation or whatever you need. You know, you need your assistant only for help you in move extractors. You know, you don't need to lose your assistant in this kind of task. The suction irrigation gives you a lot of advantage, a clean field. You can coagulate anything that's bleeding in a very, 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 very precise fashion. And the other thing is the clips. The clips, you need to have low profile appliers. It's very important that.
And so you show the non-drilling techniques for the extradural anterior clinoidectomy. I also agree with your philosophy, and I always use only micro punch for the extradural anterior clinoidectomy. So based on your many experienced cases, how is the visual field deficit after the surgery, after the extradural clinoidectomy? How is the visual field deficit?
Yes.
How late?
In aneurysm, we had 8% of partial deficit and 0.5% of blindness. And in tumors is the opposite, because precisely we do extradural clinoidectomy in meningiomas mainly in order to improve the visual function, because we made decompression of the optic nerve, and we're using a lot of pathologies in fibrous dysplasia of the bone in child, and in some other kind of tumors of the bone. And for me, the main thing about the no drill technique, if you feel in your hand the hitting of the diamond drill is terrible. Even if you irrigate continuously with the drill, always hitting when you use diamond drill, always. In no drill technique, using rangers and special instruments, no hit. I think the main problem is the hitting of the optic nerve.
Yes, and how do you perform the complete dural closure to prevent CSF leakage? How do you think about to prevent this?
It's very hard to get a watertight closure. What we do, I learned from the Japanese as well. Because I learned for the STA MCA bypass. What we do is, you know that in the skull base is very, very hard to close to the bone because we made a very, very, very high drilling, no? And what we do, we take a flap of the temporal muscle.
Temporal muscle.
Inner flap. Inner flap of the temporal muscle, and that flap we close with the dura. In that way, we can obtain a watertight closing. That's the trick.
So thank you for your introducing my clinical works to direct injection of the fibrin glue for prevents cavernous sinus bleeding. So would you please let me know how is your surgical tips and surgical point to prevent the bleeding from the capital sinus. So when the lateral wall peelings of the dura propria.
Yes. The first thing you know, the use of feeding glue must be rational, low volume, and in a stage. The first thing I do is I take out the anterior clinoid, and then I expose the Hakuba triangle, and my first feeding glue is applied in the roof of the cavernous sinus. The first one, small volume. In that way, you prevent the bleeding when you release the third nerve and the optic. The second one, when I do the peeling, I release B1, B2, and B3, and my next feeding glue is between B1 and B2. Why? Because there is where very close from that point, the most of the time, not all the patients, but the most of the time, the superficial temporal vein go there. And then this is the second point when you have a huge bleeding from the cavernous sinus. And the third point, and the third point and the most important point, is when you open the Parkinson triangle. When you open the Parkinson triangle, it's a huge opening because you have a direct connection with the basilar plexus. And then what I do is put first Surgicel. I put Surgicel, but a small amount of Surgicel only to prevent a huge bleeding. And I put the Surgicel and I reinforce the Surgicel with the fibrin glue, in that point. Why? Because if you put too much Surgicel, you compress the sixth nerve and you will have a problem with that. And the fourth and the final one is the occlusion of the superior Petrossal sinus that is going to drain there. You follow the superior Petrossal sinus to the edge of the Kawase triangle. You put Surgicel inside, and that's it. Because you must remember that the superior Petrossal sinus is round and is small. And then what I do, I put a small piece of Surgicel, and after that I coagulate. And the retraction of the dura mater close the superior Petrossal sinus, and that's it. You have complete hemostasis of the cavernous sinus.
Yeah. Thank you. So my figure out. So sorry.
Right.
And any question? Other questions?
Yeah, definitely we will take over and invite comments from the chair. But first, I would like to comment that as this topic of visual field defects following anterior clinoidectomy was brought out, I would like to mention that more than the drilling, there is a lot more to happen during the process of extradural clinoidectomy. I wrote that paper that came from Fujita in the year 2020, where we had 77 aneurysms of paraclinoid region, and of them only 2 had visual defects. And the technique that they use is the same technique as you, no drilling technique. And when I wrote that paper, I went through several literature and found that in the Sapporo experience, they found that the most important thing was for the CSF leak, they put a small muscle patch between the optic nerve and the carotid artery. Then that was found to be a significant cause for visual morbidity following paraclinoid aneurysm clipping. And moreover, in Professor Lawton's series, which came out before me, which was written by Kamide et al. In that series, they noted that use of fenestrated clips were more likely to be associated with visual morbidity. So it is more than what we think, that it is not only related to drilling, there is much more to that. So thank you very much. We can invite 1 or 2 questions. First, my co-host, Dr. Liu Bun Seng.
Thank you, Raja. Thank you, Professor, for a very nice presentation. I just want to find out from you in terms of a pre-temporal and the usual subtemporal approach for petrochival lesion. And what do you think in terms of, because of we take advantage of the stepwise configuration from anterior, medial, posterior fossa, that's allowed us to go for this technique. And in your opinion, how much the difference in terms of temporal lobe retraction comparison between pre-temporal and the classical subtemporal, and how low can you go? Because you show us we can even reach down to the vertebral artery. Your comment. My second question is, Professor, probably is good for me and also for the young resident or colleague to understand between the term extradural, interfacial and also interdura approach, especially in the medial cranial fossa? Thank you, Professor.
I think that like I tried to show in my presentation, I think that the young people, that's the way that I teach to my fellows. You need to go stage by stage. And the best thing to start to understand this, everything, the peeling of the cavernous sinus or the takeout decliner, start with the decompression of the optic nerve. For example, if you have tuberculum cella meningioma and in your service, your department, you operate with the senior surgeon and ask him to please, I want to do the decompression of the optic nerve. And when you decompress the optic nerve for extradural root, you take out the clinoid, you do a mini peeling, a very restricted version of the peeling, only release B1, a part of B2, and that's it. But this is a good exercise. The next step is treat paraclinoid aneurysms. When you treat paraclinoid, you need to go a little bit farther, and you need to release more the lateral wall of the cavernous sinus. You go up to B2. And next step that you need to go with the meningiomas. The meningiomas, because I show you here the sphenopetrocyte, but when you have, for example, clinoidal meningioma or the lateral cavernous sinus wall meningiomas, in that cases you need to perform the peeling completely. But the advantage of that kind of surgery, you don't have the bleeding from the cavernous sinus because the cavernous sinus is replaced for tumor, and the only thing you need to do properly is your dissection and your peeling. The meningioma is a very good surgery to learn how to do a good peeling, because the median meningeal artery is hypertrophic, and then you can see very clearly the foramen spinosum, and then you coagulate, you know that, and then in that point you can identify the GSPN, the posterior edge of B3, and then the cavernous sinus meningioma and the main wing of the sphenoid bone meningiomas are very good for that. And the next step is the trigeminal schwannoma. The trigeminal schwannoma is very good because in that tumor, using the middle fossa, you go to the posterior fossa, and then you can learn about the porous trigeminus and the Kawase triangle, because you can see very clearly in the trigeminal schwannoma. And when you have all that mix, all that stage you already did, you're going to take a couple of years in order to learn all of that. You can say, okay, I'm going to go to a normal cavernous sinus because I have a posterior fossa pathology that need that. And we did a lot of cases of chordomas, sarcomas, aneurysms. For example, today I didn't show you, but for example, for brainstem cavernomas, this approach is very good because you can expose all the pons, all the mesencephalon and everything. Are you question about the subtemporal, for example, the classical subtemporal or the classical pretemporal? The difference of this surgery is I use the dura mater to protect the brain. I made all the dissection in order to leave the dura mater over the brain, and only I open in the bottom, and then the dura is over the brain. And when you put your retractor, your retractor is not over the brain, it's over the dura, and then the brain is much better protected. Of course, I use sometimes a subdural pretemporal, of course, because of the pathology. For example, an AVM. If you have an AVM in the tip of the temporal lobe, you're not going to do a extradural dissection. It's ridiculous. You need to do a subdural. but the retraction that you need for the subdural root is much more. You need to try it.
Thank you very much. That was a very elaborate discussion. Quick question, definitely.
Very quick. Thank you, Professor Mura, for a really fascinating presentation. For what I can understand, if you have to operate to remove a huge tumor with cavernous sinus, with involvement of cavernous sinus, you try to remove all pieces of tumor also from cavernous sinus, as I guess. But some people, some neurosurgeons suggest to remove the tumors partially and then leave the pieces in the cavernous sinus and then refer the patients to radiosurgery, for example. What's your opinion about this kind of strategy?
I agree completely with them, because this is the thing that I want, because we have this we publish the main thing about the cavernous sinus meningioma, the intrinsic one, not the exophytic. The exophytic are very easy because you just do the peeling and that's it. The tumor is out. You can see NT2. But when you have tumor inside the cavernous sinus, it's very hard to take out. And then our philosophy is what I told you in the presentation: is the unroofing. It's a concept that William Caldwell described first. What we do is just release the nerve, because you must think about this. The median nerve is compressed here, no? It's very easy surgery, the third nerve got the same. When the third nerve entry in the cavernous sinus, you have the point where the nerve is completely compressed in the oculomotor triangle. The fourth nerve is compressed in the tentorium, and the trigeminal nerve is compressed when the tentorium entry in the porus trigeminus. And what we do in that kind of tumors is unroof the cavernous sinus, take out all the tentorium, release the nerves, and that's it. We stop. We don't take out the intrinsic tumor. The only intrinsic tumor that I take is when the tumor came from the Parkinson triangle. Why? Because when the tumor came out from the Parkinson, I have the third nerve. For example, in the right side, I have the third nerve, the fourth nerve, and then the other side, I have the fifth nerve, and in the bottom, the sixth. And then I follow that structure. But I agree that the sixth nerve is the most difficult nerve to find. It's very difficult to find. And then if you want to go inside the cavernous sinus, you have two problems. The first problem, you can make the lesion in the carotid artery. And the second problem, you can make the lesion in the sixth nerve. And then I prefer to unroof, release the nerve, and leave the patient for radiosurgery.
Thank you. Thank you very much.
Thank you very much. So in that case, we'll wind this up. Any concluding remarks from our chair, Professor Otani?
Yes, thank you so much, Professor Mura, George Mura. So I can get a lot of knowledge through your nice presentation, based about these topics, based on you from your a lot of your experiences. Thank you so much.
Right, thank you very much. So in that case, we'll go on to the second session. Thank you very much, Professor Orgemura and Professor Otani, for staying back. And we had a great learning session from you. For the second session, I would like to invite the chair, Professor Anil Pitambran, to say his introduction.
Thank you, Raja. I think I must congratulate Professor Chatter for bringing all the neurosurgeons under one roof of ACNS. See, today we saw excellent surgery, which you could have probably never had an opportunity to see without this kind of platform, because we have seen giants operate, but we know there are small giants in different parts of the world, which we cannot otherwise see. This kind of platform brings all the big neurosurgeons and neurosurgeons who have excellent surgical skill that we can watch and learn. And so much knowledge has been dispersed through this platform. And I really appreciate Dr. Raja for being consistently and efficiently expediting the job. And I think he has passed, when we had celebrated 2 or 3 months back his 100th lecture. So he has been very hardworking, and he had successfully put forward several people and put several people, several young neurosurgeons, famous neurosurgeons into this platform, so that we can watch them and share their knowledge, and we can discuss our issues. So coming to the talk by Imad Talame, we all know that lumbar fusion is such a complex topic, and you need a lot of skill, a lot of instruments and a lot of infrastructure to do this. So today we'll be discussing about lumbar fusion in limited resource setting. It is a very important technique in countries like us, where we have low income or middle income countries, developing countries. Sometimes we cannot get all the instruments and infrastructure we need to do. So I think we can listen to Professor Imad Salame regarding his techniques. Professor Salame, please continue.
Thank you very much. I don't know if I can load my lecture. Thank you very much. I'm Dr. Imad Salame from the city of Hebron, Palestine. I have a double citizenship. I am Italian and Palestinian, and I'm working in this country, poor country, and still under occupation, and we are still facing time to time war in our area, and therefore if we speak about resource limiting or few resources, I am in the correct place. And when you are a neurosurgeon and you love your job and you have your country and you love your patients, when you cry for your patients, you want to to have solutions. And my history began from outside before coming to here in Libya, but I want to emphasize some concepts today because sometimes our mind is limited to what has from the learning area. If it is rich area like America, Italy, or other, you have in mind just sophisticated tools and these things. But when you are in limited resources, it is not easy to act, and you feel not safe to act, and you feel that you can have problems and troubles because you are always doing with people, not with animals, not with mute things, because if something is coming wrong, you can be blamed, even you are in country with very limited resources. This is the human nature. They need us to be perfect. They need us to have 100% success. Even the patient is really severely injured. At the beginning, do what you can do, but after that, they discuss with you everything that you are doing. Therefore, I was living in Italy. Italy is a good country. The health system in Italy is really supported by the Italian government with a good piece of the budget of the Italian national budget. Therefore, it's easy in Italy now to find MRI machine in the operating theaters, not the C-arm, the simple C-arm that it's produced all over the world today, not just used. But my problem at the beginning was how to find screws or proper screws. Sometimes you find that one company can bring to you trial screws. After that, it's already finished, or you cannot have cages. And sometimes you need them, they are costly to the patients. And during the war, I was in Libya. Libya is a very rich country. I was in a mission with France people, with France government there to create a hospital and neurosurgery department. The uprising of the Libyan people began, and in the few days, or the first month, all the stuff that I have in the theater was finished, and but the number of patients was all the days more, and therefore you must learn how to save the life of patient in these conditions, and slowly you can learn, and you can teach that to your neighbor or to people who are in the same conditions. When I was in Libya, some of the Libyan professors came from outside, and we have got injured people. I asked them go and act, and they go to the theater, they didn't act because they don't have in mind how to act without microscope or without screws or without what they can do. And here enter the what we have learned like neurosurgeon, what to save first, because if we can speak about people who are coming with burst fracture unstable or cauda syndrome or anything like this, we must teach people from the beginning how to do laminectomy, because it is life treating for the spine. This is the most important procedure that they can, first of all, decompress the neural structures to save these neural structures. and in war sitting or in countries where sometimes you don't have enough stuff, or you cannot bring the stuff immediately during the night or within 1 day or 2 days, even the patient needs fixation. You cannot leave him with his deficit, with the cauda syndrome or with spinal cord compression till you have the stuff to make fixation. You must act at the beginning to preserve the neurostructures, and then you can make second time to make fixation or something, or you can send him like that with the ambulance to another country, to another city. Therefore, we must act like neurosurgeon. That's what I want to emphasize, that the concept, if you have a patient, you mustn't leave the patient to his to the bad future. No, help him at the beginning to preserve the neurostructures, then speak with him and with the family. You can go to other city, you can, but I cannot stand up now because you are unstable. At the beginning of my life, microscope like this I cannot use in Italy, the covers everything. When I went to Palestine from Pantero microscope, I began using the smaller microscope. I am doing stereofossa surgery for children, and with this microscope and with this gloves, this is my daily life. Fortunately, we have new microscope in some hospital in Palestine, but I did, there are about 8 years that I'm using this microscope when I go back to Palestine. But I did a huge number of surgeries, cervical or spinal tumors or brain tumors, using this way. And do be careful not to touch the microscope from the sterile part. Many times I have canceled surgery in Italy because we didn't have cover for the microscope. Now I am I speak to myself, why I canceled. I lose 1 day because it was easy to put 2 gloves, but you can learn from the others. When I was in Libya, who came to help me first, the Egyptian neurosurgeons. And you know, Egypt is not a really rich country, and they began teaching me that look, in Egypt it's not easy to find these covers. We use okay, I can use also the gloves to cover and go on. My fear, at the fear of everybody who are doing fixation, dorsal, lumbar, or cervical, if you have just one C-arm, or if you don't have the C-arm and you must do it, how you can? Many times you are not sure that you can do it without C-arm. But when you try, when you know the anatomy, when your sensitivity in your hand, and your touch, you can really feel the pedicle very good. You feel the cancellosa very good. Sometimes you use your ear to sound some things that would help you. Slowly you can begin to trust yourself, and you can begin like putting 14 screws, 16 screws without using any X-ray image. Just after that one image, and could be enough after the experience. But this experience cannot begin quickly. You must try first to do safely in your patients, and after that slowly you feel that you don't need XC-arm a lot. You need 1 shot, you need 2 shots, even for very big surgeries. And one of the most difficult situations that I have faced, how I can make external AVDs, external drainages, for many patients here in Palestine or in Libya, and the silicone or the proper tubes wasn't not easy to find. It is costly, or it's not easy. I began thinking to use the plastic tubes or the suction tube. They are elastic. The RES, it is not enough. They can harm the brain, but you are in angry brain, or in brain that you need to lower the ICB, and you need to use them. And I began using them, and now it is normal for me. It's a habit to use the suction tube that cost $1. You can buy 10, and you can use, and it is our life here now in Palestine. Another thing that I can tell you from the beginning of the time that I came here, it is not easy to find something to suture the dura or to, I begin suturing the dura with the silk sutures. This is the way. Sometimes the patient came very good. Sometimes somehow the bone is depressed 2-3 millimeters, but we solve the problem of our patients. Therefore, you mustn't stop, I think, like a surgeon. If you can, the main concept of the shunting or for the heart for the external shunting is to have something to do, to go there good in good hands. If you use even this not enough, it's harm. Yes, it's harm to brain, but you can use it. You can use it, and we have got a good results. Really, I didn't find any problem with that. The problem how to connect it with other things to be sure that you are shunting proper quantity of CSF. And here you can speak with your nurse, learn your nurse about the quantity, how to follow, and these things slowly. For the subdural hematomas, even in the very small hospitals here in Palestine, you need to have a drill system, even manual, because sometimes it is not easy to bring the patient from one city to another city. It is divided, the country is small, but also it is divided by checkpoints from the Israeli armies. And therefore, for us doctors, we have tools to open to make bar hole in every part of, in every hospital, we can see. Therefore, how to put drainage in the subdural area? You don't have a proper silicone drainage. We use the Foley catheter. It is easy, fenestrated more and more, and use it. And now it is good. It's a habit for us, not a problem. We have good result even for that. My talk will be about everybody working in Europe or in America or which country, he make fusion with cage, because we know that if you want to have a good surgery, it's not enough to use screws. It's good to make fusion and to use cages to preserve the disc space and to the sagittal alignment and these things, all the geometry of the spine. It's good to use cages to have a 360-degree fusion. And it is not, when I came to Palestine, it wasn't easy to find these cages. And when I found them, the surgery was costly and the people cannot really pay. But in my idea and in my habit, I cannot operate without cages. I began thinking how to solve this problem. I began using just one cage from one side. And this was good from the one side, but after that I didn't find cage. It is not easy. It is costly also. You cannot make here a fixation, making the people paying like $10,000. You must range from $4,000 to $6,000 maximum. And this is the problem, how to have low-cost screws and low-cost cages. And the companies cannot give you something for free if you are not using a lot of screws. The fusion for the spine is essential. That's what I want to emphasize. You cannot use just screw because it can be broken. You can have problems after that without using the fusion system. Many things we can use to make the fusion. We can take bone graft from any segment of the spine they are using to fix. In my habit, I am using to have a bone from the site of surgery. I don't go to the iliac crest. I don't go to the artificial bone because the artificial bone is always artificial. But when you have your autograft bone or your bone from the site, you want to do laminectomy or fenestration, preserve that piece of bone, preserve it very good, and introduce it in the disc space. Here you can have the best environment for the best bone graft. But if you use artificial or autograft or allograft, you can have a delay in the fusion. But when the bone is from the same patient, after 2 weeks, the first X-ray you do for the patient, you can have fusion. We have many kinds of approach to the spine. Everyone has in his mind, I like that, but I feel that the TLEAF is a very good solution for most of our patients. And to obtain a successful result from a spine fusion, you need many factors. Really, I'm facing difficulties with people who are smoking a lot. I got patients are smoking 3 boxes by day. These people are always in bad, or the wound will be bad, the fusion will be bad, the result will be bad. And many people they are fear about the how I can move about after surgery. I used to make my patient going out of bed within 1 or 2 hours after surgery, quickly. I don't like them to stay in the bed, to encourage them to move more and more, because many people are afraid and they came to you with the rigid back after that. Therefore, to have a good result, you must not be a good technician in the fusion. You must learn or teach your patient. You must speak to your patient how to use his back after surgery, how to clean his wound, everything. Even it is simple, and you feel that it is not important to tell. No, in poor countries, some people they didn't have money to go to doctor to make a dressing for the wound, and he came to you with infected wound and need to have antibiotics, and now it is costly. Therefore, every detail when you are in poor country is important, because the sterility is so important in the theater. But after that, people sometimes they can keep the dressing for many hours or many days, and they came back to you with infected wound. Even if subcutaneous can go inside, and they will blame you anyway. I don't want to speak about many details, but what I want to emphasize, here I have a case of 4 cages anterior approach. This lady, poor lady, and she asked me, I want to make this surgery. This surgery cost about $5,000, no less than $5,000, and it is anterior approach. I don't put the prior image. This is my way. I take from here the osteophytes. If you see here, it is open all the bone from anterior to the spinal cord, and I put them in the cage. It is normal for me to do 4 levels from anterior, mostly for the young people. Young people, I mean less than 60 years old. But for the older people, this case is a crucial case in my life. This is Medtronic system. The cost of this instrumentation was about $20,000 at that time. Why? Because it is not usually used in Palestine. And when the company bring these tools to me, they pay for the tools, they pay for the export, they pay a lot. Therefore, after this case, the hospital director told me, Imad, excuse me, yes, we need to do this good surgery. This was done in 2012. But this patient, we lost a lot of money because he couldn't pay this amount. Thank you. Do not repeat this surgery again. But I have patients. What I can do? I begin thinking how to do surgery using the bone. This stasis of L4. I took the posterior arch, and here all the posterior arch. And this lady, after just 1 month, she came back with the fusion beginning. What was the idea here? Because many people, this is the bone fragmented. I put always gentamicin on this bone to make it just to be sure not to have infection. we clean it very good from the fibers, from the ligamentum, and we put gentamicin on it. After that, we remove the cartilage around the disc and we insert it. Here, this image is about 3 weeks after surgery, not 3 months. This patient now may have all the space full of bone. Look, when you clean very good the disc, you can put a lot of bone, and this patient will came to you. This is the same patient of before. After, this is the same patient of before. Look, the bone begin making effusion. This bone is free of cost because it is from the same patient. And the screws made in India and is imported by Turkish company. And it is not costly like the American made. From India, you can find something with 15, like you can say if it is $1 in India, it is $5 in America, and it is good quality. It's enough for us. Therefore, I am not like the people who like markers, like just Mercedes. I can guide the Tata car, and I am happy because it gives me what I want to have. And this is why I emphasize in Palestine. Now in the Palestine market, we have at the beginning, the cost of one screw was more than $600. Now we can have screws with about $100 in our theaters. This is very good. I think that I help my people to have easy fixation, and my patients now and my colleagues now are happy. They can have a lot of them because many of companies now are bringing from India and from Turkey cheap screws. The important thing for me is to have to be sure that this screw is titanium, not something that therefore I use in my life to use these screws, and especially for the traumas, and to remove them after 6 months and to talk to them how they are. Therefore, after trying these screws, I encourage my colleagues and the hospitals to deal with these companies, because sometimes you can have screws not pure titanium, and this can harm our people. Look to the fusion. It is fused completely in short time. This man was 140 kilogram, 7mm screws. You cannot easily put cage here, but when it is bone, you can have, look to the stages before, you can have easily fusion. Here you can find how it is the pieces at the beginning, but if you do the CT scan after, you can find that it is totally fused and they become one piece. Just cage with bone inside is good. It's good, like in this case, okay. But even you are using cage, if you put some bone around the cage, like the case I did before 2012, it is also better, but it can be enough just to use the bone. Sometimes they ask why you don't afraid that bone escape from it escape from inside the disc space. I preserve the capsule of the disc. I remove the disc, I clean the end plates, and after that, after putting the pieces, I push them with bone impactor, and I am sure that they are good. After that, when your screw is closed very good, and the bone is from the patient, and you talk to your patient to move slowly at the beginning and to be careful when he sit down, when he go up. In 2 weeks, this bone will be one piece. I face just very small part of people who has got escaped pieces of bone without any symptoms, just because they have another thing I did for them, a CT scan or something. I found that some of the piece was escaped. Here, look, 3-level fusion. You can see posteriorly that I have took this angle to decompress and I put it here. This is 1 or 2 months after. Here you can see the stitches, and the fusion begin very good and without any problem. Therefore, in such case, how you can use the cage. It is sometimes better to use the bone graft, good bone graft, than this is very young lady, I think 16 years old, and the result was very good, and she was sometime you need for some patient to have technology, to have screws for anterior and posterior approach, like this boy falling in a pool. I operate him anteriorly and posteriorly with laminectomy, fusion. We have the possibility to operate when we have screws, when we have plates, when we have everything. We can do the good surgery. But when you don't have it, you can wait. This photo for this patient, this is K2M cage, and this is after 6 years. Look, there is no fusion. These are my patients. At that time, I found this company in Israel, and I asked to one company to bring them. They are costly, but this is a bone graft, and the fusion is not like when it's from the same patient. Really, the autologous bone is the best bone to be used, and this is one of my cases that I cannot operate. She has low back pain, and the MRI shows this ectasia of the dura. Thank you very much. I take it somehow short because I think you have understand what's my idea.
Oh, excellent experience you have shared with us, Talabe. The thing is, I have seen that you have done a standalone cage for 4-level cervical spine. Would you
Yes.
immobilize with the collar after this? How long do you do that?
3 weeks, 3-4
That's
weeks,
all.
because with the autologous bone, you can found, when you look to the X-ray, you can found that you have early fusion. You look to my cage, I fill it with bone, pure bone. I clean the endoplates until I see the blood coming from it. Understand? It is
So
really.
you crush the bones before you put it.
A small. It's just I used to clean it from the fibers, from the soft tissue, and after that I put it. But I used always to use gentamicin. I have really very low rate of infection in the cervical spine. In 10 years, I have one infected patient. In the lumbar, more especially for people uncontrolled diabetes, I have a lot here in Palestine. People who are smoking a lot, I have a lot here in Palestine. These are two categories very bad for us, like neurosurgeon. But really, in this in situ, I wash a lot with normal saline. I wash a lot before closing, and after that, I use gentamicin on the bone before and after. After everything, before closing, I leave a pure gentamicin in the wound.
Okay. Why do you avoid iliac crest? Is it because of pain or because of the tedious process? Iliac crest graft. Why do you avoid iliac crest graft or cancellous bone graft?
You know, because of the harvesting site pain, because many people are having myalgia or the pain there is more, and because it is enough to have. Even and when I came to Palestine, most of my surgery was redo surgery. People operated before here and there, and it wasn't easy to find so much bone. The idea was this is small bone, but you clean the endoplates very good of the disc, and this is small bone many times have got a very good fusion. Sometimes I use bigger screws and longer screws to have more fixed segment to leave this bone act and become a piece of bone.
I know, but the thing is, when you put a small piece of bone, there's a chance that the vertebra might settle. So did you have any chance of screws breaking following this?
Really, I have got some of screws breaking and some of rods breaking, even it's fused, it's fused. And I think in my mind that, you know, the bone morbidity or the bone density and the screw density is different. Sure. And even if it's fused, you can have broken screw, but without pain, without a problem. Okay. They find it because they came to me, low back pain. It was due to sacroiliac joint disease, not due to the screw, broken screw. The fusion was enough, but you know, it is bone fusion. The mobility anyway, the bone can be compressed anyway during the mobility of our spine, but the screws cannot move. This why you can't find the broken screws, and you don't need to replace. You can remove it completely.
So you mobilize them very early following surgery, lumbar spine?
When they are awake from surgery, full awake, I mobilize immediately.
You're a very versatile
patients, except people with large dural defect. I can have it. It can be at the beginning. You have a lot of them. Now it is not easy to see them because you are more accurate in your surgery. But when you have a large defect in the dura and you repair it, even I repair it, I keep them 1 day more.
Yeah, I think one advantage with Indian instruments, we got good titanium instruments per screw costing $30 to $50. That's very advantageous. They have very good material also nowadays.
Yes. If I'm
so you talk to your Indian neurosurgeons, they can tell you which is the best screw to pick. So that's
yes.
Yeah. So Raja, I give it over to you for any questions to be asked.
Yeah, definitely. There is a hand raised by Dr. Ajit R. Yes, Professor Ajit R can ask. Hello. Yes, sir.
So it's a very, very good paper. In the sense that many tips he said that we were using some years back, and it's a very useful in resource limited places. So I can give you a few tips. One is, if you don't have a gel foam, surgery floor, that is a flowable gel foam, you can gradually, with a knife, you can scrape it slowly into small pieces and fill it in a syringe. And with a little saline, you can inject. And this will be almost equivalent to the surgery floor or floor seat. This is not my technique. It's already taught me by my friend Dr. Ramesh, who is regularly using this technique. Another thing regarding the cervical spine instrumentation, if you have a single level disc radiculopathy, instead of going for ACDF, you can always take a posterior cervical foraminotomy, which you don't need any implants, and in where when these resources are so limited, you can save you a lot of money, because many implants we use are being promoted by the industry. So even in a T-lip, you can use you can make a cadaveric bone bank, and from the cadaveric bone bank you can put the stud cages inside instead of filling the loose cancerous bones. There are so many things that can reduce the cost and that are locally available. That is what I just want to express regarding the his effort to maintain a good neurosurgical service to his patients in Paris.
Thank you, Ajit. I think Ajit actually had worked with us in a low setting, actually in medical college. So he has got a lot of experience.
Right. Thank you very much. Alberto, you want to contribute something?
I just want to congratulate Dr. Imad, because I understand that, Prego, I think you know Italian because you spent some time in my country.
Lo parlo come l'arabo.
Oh, very good, very good. So I think in limited resources setting, of course, you don't have so much, but you need a lot of fantasy, right? So you have to find the solution by yourself. I have just a question. In your country, is the patient who has to pay for his own surgery and for instrumentations? Or is it the hospital or the government that pays for like screws or clips or whatever?
Some people have the insurance, public insurance, and if they get coverage by the government, and it's difficult because of the bad economical situation of the government, they must pay about 30% of the cost of the tools, of the screws, of the consumables. That's why it is interesting to reduce them. Now I am thinking, I spoke with the Red Crescent, like the Croce Rossa Italiana, like the to create a neurosurgery unit, beneficial one, to solve all these problems. Because my problem when I want to put neurostimulators or deep brain stimulation, these are the apparatus costly, not just the screws, because I lower the price of the screws in the market. Even the MRI imaging, when I came to Palestine, it was $300 to make one section image. Now it's about $120. I make conflict between hospitals. They buy a lot of machines. Now I can have images for my patients. You know, you are not thinking just to do a good surgery. You are thinking how to help your patient, having images, having medicines. Understand? You are prescribing diclofenac sodium or any another medicine because it is not costly. In Palestine, 5% of the people, they can pay everything, but 95%, if they pay, they will take this from their food. They have to live, but if they want to pay for their health, they will take it from the food, or they will stop their children from the university. Therefore, with feeling to help my people, I'm happy for that. Really, I think that I make success, because now many of the Palestinian hospitals are operating. Many of my young neurosurgeons coming from outside, from Europe, from Germany, from Jordan, when they came, I helped them to begin and to absorb the shock, not to found always see arm, to feel better when the screw is going in and these things. And from Palestine, after 5 years, you will find good surgeons, inshallah.
You are doing great job.
Thank you.
Congratulations.
Your country should be proud of you.
Thank you.
Doing so much for the patients from
That
their
I
side.
think we can wind up. I will go back to our chair, Professor Anil Pitambran, to give his concluding remarks.
So I think it has been a wonderful day today. We had two superb lectures, one with an excellent display of basoskull surgery, another with a limited resource setting, how we can do service to the patients without costing them much. So Raja, I really congratulate you for selecting these two topics. I think we can wind the session today now, and good night to all.
Right. Thank you very much. So in that case, I will wind this up. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to sincerely thank both the speakers of today, Professor Jorge Mura and Professor Imad Talama, and the chairs, Professor Naoki Otani and Professor Anil Pitambran, for the time and support for the ACNS webinars. I would like to thank both my co-hosts, Dr. Liu Bun Seng and Dr. Alberto Felitti, as well as the distinguished audiences who joined from all over the world today. A special thanks to Professor Shubin, who is our main mentor from China, for his support and broadcasting this webinar in WeChat. Today, there are 975 participants who are watching this live on various streaming platforms. So until we all meet on next Saturday, it is bye-bye from all of us. Thank you very much.